that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Hello and good morning once again. Welcome to this morning's edition of our CATHIP Health Hour session, which is the Caribbean and African Targeted Health Improvement Programme, which we hold Saturday mornings, where we have Black consultants and Black GPs and Black doctors come to share their experience with us, their knowledge with us, to equip us and to empower us, so that we would know better and we will be better equipped to deal with our own health issues and to help other people. I know that we've all had a very somber week in the sense that our Queen passed away, sadly. May her soul rest in peace. But we also know that we have had King Charles III take over. And so very trying times, very sort of unsettling and quietly meditative times for all of us as a nation and even as a world. And our heart goes out to the royal family and to everyone who has been affected by this news. My name is Dr. Diana Asante, and I'll be your host for today while we host our CATHIP Health Hour session. So welcome once again. We value your time, we value your inputs, joining us every Saturday, coming in to make these programs a success. Week in, week out, we bring you interesting topics that would help stimulate us and evoke discussions as well. And today we do have another very interesting topic to discuss, one that, although relates to women, cuts across because it's relevant to men, to children, to the whole family, because it affects all of us one way or another. And as usual, we also have a very seasoned speaker to talk to us today. So the topic for today is hysterectomy. Do I really need one? Hysterectomy, do I really need one? And we do have a seasoned and very experienced consultant, obstetrician, gynecologist, who has spared her time to come and talk to us today. She's a consultant with the Rotherham Trust. She's a lady who wears many hats. She's into public health, research work. She's even doing a degree in a PhD rather in law and criminology, but she will introduce herself in greater detail. Now, once we've gone through our session with our guest speaker, we also have a special guest today who will be telling us her own lived experience about having had a hysterectomy. And then we go into our Q&A session where you have the opportunity to ask questions, to share your own experiences, to interact, and for us to have that conversation that makes this program very special and very stimulating for everyone. Welcome once again, and it is my honor and pleasure to introduce to you Dr. Lorretta Oduwari Ogboro Okor. Over to you, Dr. Lorretta. Welcome to the CATHIP Health Hour, and thank you so much for honoring our invitation. You're looking absolutely stunning.
Thank you very much, Dr. Diana Asante, and I'm really pleased with the way you pronounced my name. Well done.
Got it right, hopefully.
You did. My name is Lorretta Ogboro Okor. And before I even say anything, I would implore all of us the world over who are logged on to kindly spare a minute of silence for a woman who was the matriarch of the world and who helped keep everything in. Love her, hate her, there's one thing we can't take away, and that is that she exuded a form of unifying factor, mentoring young girls across the world. So please, a 1 minute silence for the departed Queen Elizabeth II of the United Kingdom and the Commonwealth. May her gentle soul rest in peace as we all welcome King Charles III. Thank you very much. So without further ado, I welcome every one of us today. My name is Lorretta Ogboro Okor, Oduware Ogboro Okor, and I will go straight to sharing my screen. And the technical team will let us know if my screen is showing up nicely the way we want it to. And if I please ask everyone else who is not speaking to kindly mute their devices, as well as it would help if we all label our devices with our actual names, just especially for question and answer as well, because I'm seeing iPhone 1 and Samsung 4. So hysterectomy, do I really need one? I commend CATHIP and all here today for the time they are spending in improving advocacy and health-seeking behavior of our people, because that's what we are doing. So you already know, my name is Lorretta Ogboro Okor. Actually, it's Ogbo Okor. The R is silent in the first hyphenated part of my last name. And I earned my MBBS degree from the University of Benin in Nigeria, proceeding to come and do a master's in public health research at the University of Edinburgh, where my dissertation at the time was on post-abortion complications in southern Nigeria. Started working in the NHS over 15 years ago and have risen to the level of consultant obstetrician and gynecologist following attaining my MRCOG with Royal College of Obs and Gynae. I've done an MSc as well in clinical education, and I am a simulation expert working with prompts and faculty in Doncaster Basel. I didn't stop there. I decided that I needed to impute into the effect of trafficking gynecologically on women who have suffered that ill. So I'm doing a PhD in law and criminology with special effects looking at trafficking. I am very passionate about tackling women's reproductive health and their mental health issues, but understandably, women do not live in isolation. They live in societies across the world. So that means I have the unique opportunity of interacting with their partners, their relatives, and their children in some instances. I'm an author of the book, My Father's Daughter and Heartwebs. Just type this on Amazon. And overall, I like to see myself as a positive disruptor of any space I find myself. So it's a rare privilege being here today speaking to us. Now, I'm going to keep this very, very simple and try and avoid all the medical jargons, because I sometimes find that in passing information across as healthcare providers, that is one place where we fall flat. We speak, but sometimes we don't communicate, because there are two different things. You communicate when people understand what you've said. So let's go back a bit and see where this hysterectomy, what's the meaning? Where does it come from? I'm sure all of us may have heard about the word hysteria. Hysteria used to be a diagnosis many years gone, and it was an uncontrollable outburst of emotion, fear, a roller coaster wave of feelings exhibited by people. And at the time, people thought, mostly women. But where did the word hysteria come from? Because that is exactly where the word that has come to mean the uterus has taken its roots from hysteria. And it was the Egyptians many years ago who thought that there's a theory they propounded, which they call the wandering uterus, and it's linked to irrational behavior. So they thought that there was an animal within the animal, and that little animal, they called it the uterus or hysteria. And they thought that that animal used to move around the body, and sometimes when it moved from where it was in the lower abdomen into the head, then there was irrational behavior. That's really weird. But hysteria is where that word is coming from. And in comes the Greeks, who said, okay, we agree with the wandering uterus theory, but we are now saying that when this uterus wanders, it causes suffocation. So they came up with hysterical suffocation. And that also, they added on to that these women who suffer this do not have children. They often don't want to marry. Their emotions are not stable. It took the Romans coming along to say, okay, now we've found out a theory that this uterus doesn't move about, it doesn't wander, it's one place in the lower abdomen, and we'll still call it hysteria, but we don't have to put things through the vagina to get it to come down. It is in one place in the lower pelvis. It is hysteria. Galen came in modern times of Europe and propounded that the uterus was fixed and that hysteria was the fixed disease of the uterus. So over time, that word hysteria, look at the differences in spelling. Hysteria with an A, hysteria, hysterios, uterus became the Latin version. And today we have uterus. But in effect, all of these words, we just mean the womb. And you can see the picture of the womb there, nicely pink within the pelvis. And when I say the pelvis, I really mean the lower abdomen or the reproductive tract of women. So hyster means womb, ectomy in medicine means removal. Removal of the womb is simply hysterectomy. It can be complete, total, where you remove every single part of the womb, or it can be what we call a subtotal. It can be done open. That means you have to make a cut and you are taking the womb out or parts of the womb, or it can be done keyhole, which we call laparoscopy. It can be removed, like I said, with all its relatives and nearby structures. I like to call them that. These are the ovaries, the tubes. It can be removed with them, or it can just be removed alone. Now, what will determine the kind of removal we have are the individual presentation, demographics, age, fertility needs of the woman, and we'll come to all that. Before I forget, I'll just point out that when you hear otomy, that means opening up, but not taking out. So there is a word called hysterectomy. And if you think about it, a cesarean section, you are cutting into the womb, taking out the baby. It's actually a kind of hysterectomy, otomy, not ectomy. Ectomy is completely taking it out. And fibroid removal, for example, can happen when you've done a kind of hysterectomy, but that themselves are called myomectomies. Now, let's take a close look at this uterus. What does it look like? This famous organ that you see in women. It is described as a pear-shaped organ. And if you look at it, it does look like a pear, doesn't it? These are fancy diagrams. I remember when I first read medical books and I saw these pictures, I was like, wow. It's different when you go inside the living body. When you go inside the living body, it's going to look a lot more when you're looking at your screen, like the pictures on your bottom left-hand side, where you have it labeled. The uterus is there, and you can see the ovaries on either side, the whitish little structures. And you see this nice tube on the picture on your right, how they just look like they are just stood there. When you go in real life, they are not like that. They are, sometimes you have to search for them. They are flattened, they are turned around, they are stuck sometimes. But I think I just wanted us to have a look at what the images are in the books versus what it is in real life. Now, the image on your top left-hand side is actually the inside of the womb when you come in from down below through the neck of the womb and you look with a camera with water expanding the inside of the womb. So the womb is like a cup that you've turned upside down. You can see that it's pear-shaped. And if you look at the image on your left top side, you will see two little dimples on either side of that image, like two little holes. Now, those are the openings of the tube into the top of the womb. I mean, the womb it's a perfect machine. And I just thought, let's take a closer look at it. Let's take a closer look at what it does. It has a body, it has a neck as well. It has an opening into the vagina. You'll see that in a moment. So look at that. This is the womb on your top left side. It's cut into what we'll call a vertical section. And you can see the space inside of it. You can see the body of it. You can see the lining inside it. You can see the tubes, once again, coming and touching the ovary, which sometimes they don't do. But the primary function of the womb is that it carries our baby. We can see a baby in the lower right-hand side one. And you can see the neck of the womb very clearly in the lower right-hand side one, opening into the vagina. And those little creases you see within the vagina is called rugae. It helps it expand. So in a nutshell, this is us looking at the womb and understanding its function, and obviously the ovaries by its side. So please, everyone, hold this picture in your mind's eye because it's going to come back as we go through this discussion. So is a hysterectomy for me? Is it for me? Is it for you? Is it for the other woman? Is it for a woman in Britain? Is it for a woman somewhere in Accra, Ghana, Kenya? Is it for a woman in the Caribbean, TNT? Who needs a hysterectomy? I think to answer this question, we must first of all understand that each of us is unique and we are each fearfully and wonderfully made. And that this procedure is a big life-changing procedure. It's a major operation. It's not a joke. And recovery can take a while. Now, it then behoves us as healthcare providers to actually take each of our patients as the fearfully and wonderfully made specimen they are and individualize their care while managing them holistically. So what do I mean by this? What I mean is simple. If you take a 10-year-old girl child, what that child needs at that time is very different from when that child becomes 20 And it's going to be different from when that girl or woman now becomes 30, 40, 50, or 60. So if a woman walks into your office, you must look at that woman as an entity and not just a statistic. She has issues or things that are pointing you towards a hysterectomy, but must it be done? And if it must be done, does it have to be at that time? You must put her in the center of care, because our women need to make holistic, patient-informed decisions. So now let's go on and see what kind of conditions these women may come with and how each woman could vary. And that actually would be a function of the conditions that the woman has come with that may have hysterectomy as the management solution, either on the short, medium, or long term. I want us to break it into two big subheadings: the conditions that can lead to a hysterectomy. There are the benign ones, which are things that are not necessarily cancerous and things that could happen. And then there are the cancers. For the benign ones, we have heavy periods. And many women have a different experience of their periods from when they start at menarche, which is what we call that, to when it ends at the menopause, which is when the period ceases. Some women have very heavy periods, but they are still able to manage. They have pain, they are still able to manage to do their daily activities. But when it begins to impact on their quality of life and they seek help and they come to you, how you manage them will depend on what stage in their life they are at. Have they had children? Have you investigated them, done the ultrasound scan, taken a good history, and identified the possible cause of the heavy bleeding? Is it because they have fibroids? We'll come to that. Or is it they have what we call adenomyosis? And I will explain that as well. So fibroids are non-cancerous growth within the womb. And adenomyosis are actually when we have the lining on the inside of the womb actually being anywhere else but the inside of the womb. So anywhere it is, when you bleed during the menses, that place bleeds as well. So imagine that picture I showed you before of the womb. Imagine, sorry, I just want to take us back. Imagine actually, just a second. Imagine that you have the lining of the womb, not within the womb here, but in the ovary or in the tubes. You can imagine the pain that woman would be in every month when she bleeds. So you must exclude possible causes: endometriosis, adenomyosis, fibroids, and of course, the diagnosis of exclusion, which is the dysfunctional uterine bleeding. Some women just bleed heavily and they don't have a quality of life. They soak through pads. Has this woman had children, or does she desire a family? If she does, you're not going to just go there and yank out the womb. You're going to think of other things and how to manage this to suit what she needs at that time. Then you have the long-term pelvic pain, which can be caused by the endometriosis, like I've explained, and obviously when you've had infections as well. And fibroids, depending on where they are. And again, fibroids are cropping up again as non-cancerous tumors. And of course, you have when the womb or the adjoining structures are weak, what we call pelvic floor prolapse. Or sometimes in rare cases, the womb just falls out completely, procedentia, in older women who may have had many children, or they are big in size, or they have connective muscle disorders. And then of course, post-setting procedures, post-abortions, women get infection. And to save their life, we sometimes may need to take out the womb. Or when a woman has delivered and they are bleeding a lot, and as a last resort, to save their life, we may need to do a hysterectomy, a womb removal. Now, let me zoom in on fibroids because I appreciate the fact that I'm speaking on a unique platform, an Afro-Caribbean platform. Fibroids are very, very common for some interesting reason in us, Black Afro-Caribbean women. 3 out of 5 Black Afro-Caribbean women, wherever they are in this world, are likely to have fibroids, whereas you have about 1 to 2 of Caucasians. People have attributed it to dietary factors and all of that, but there is no clear-cut pathway. It is just like that, and we have to, once we know, knowledge is power. Then you have the cancers. It can be the ovary, the womb itself, in any part of the womb, the body of the womb, the neck of the womb, or the tubes. And these are reasons why you may then decide that, okay, a hysterectomy should happen as part of management. And these are fibroids. I just wanted to show us quickly because it's unique to us, where they can happen and how they can present. So if you think about onions with rolls in them, layers, that's how fibroids are. They are whitish, and you can see that they can happen here inside, protruding inside the womb, within the muscle of the womb, or more closer on the outside, or just stuck inside the muscles and all of that. Wherever they are, these are examples of when they've been taken out. Wherever they are, acting on them would be dependent on what symptoms they are causing. Are they affecting fertility? Do we need to remove them? Are they making the surface area of the womb wider and causing bleeding? Do we need to remove them? So these are questions we need to ask. And this is endometriosis, which I was trying to describe. You can see that black chocolate-like thing beneath the womb here. That's a collection of menstrual blood every month when the womb bleeds. But because it's in the wrong place, it's obviously not coming out, and it's stuck there, causing a lot of pain. And this is a real life image at laparoscopy, while the other one is just a drawing from a book. Now, the facts about hysterectomies is the second most common surgery amongst women. And in America, I was looking at the health stats, about 33% of women will have hysterectomy, and you just wonder, are they really needed before the age of 60? How do you then decide to manage this? You can just say that my patient has come to me. She's having heavy menstrual bleeding, and I'm using a real life example now. And I have investigated her. I've done the bloods, I've done the scan. I can see a small fibroid. But this patient is only 39 years old. She has not had a child yet at all, but she's bleeding heavily. Are you going to go there and take that womb out? No, at that point, you will look for an alternative because she wants children. You are going to think, can I take out that fibroid and save the womb at that time? But then consider a woman who is 49 years old and she has a 30-week size uterine fibroid and she's bleeding and bleeding. She's having low blood counts. You are going to discuss with that woman. She's had 3 children. What are you going to do at that point? Ultimately, at that point, that woman could benefit from a hysterectomy, a removal of the entire womb. So this is what I'm talking about. And we must note that it's only 10% of hysterectomies that are done for cancers. Many hysterectomies, removal of the womb, are done because we want to improve the quality of life of this patient. And sometimes some people may tell you that you may get fat after a hysterectomy, you may grow facial hair, you may become depressed. Yes, that may be true, but it's transient. And some women actually get upset and feel a sense of loss. But everybody is different. And this is why you must warn people. There is an overall cost of having a hysterectomy that we should look at. And this will affect the type, the method, the complexity. You need to know, is it caused by benign things or is it cancerous? Who can do it? What is the expertise of the gynecologist that can do it? Can it be done in the public or private sectors? These are questions that we need to answer before we jump in to do anything about having a hysterectomy for whatever reason. And the alternatives, I really want to dwell on the alternatives. And we must realize that the alternatives to having our womb removed would be dependent on what is causing our problem, what we want, what stage of life we are in. So what are the alternatives? The first one is do nothing. Do nothing. If a woman is bleeding, you can't explain the cause of the bleeding, but she wants to have children. Dysfunctional uterine bleeding, it's called. Heavy menstrual bleeding, HMB, you see, different names. You can do nothing because she wants to conceive. The other thing you can then think about, I'm grading this now, you can decide medical management. Will she benefit from drugs, e.g. tranexamic acid, mefenamic acid? Can I use that? Is the fibroid small enough that it will work? Because this can work in certain women. Or do I need to create an artificial menopause using what we call the gonadotrophin releasing hormones? That's a big name. What those medications do is that they go and tell the brain, don't have periods, create an artificial menopause. And that's what the womb does. The womb obeys because it's a feedback system. These days, we have what we call the Mirena IUS, which in the United Kingdom is actually the first line of management according to NICE. Where you put it, it's what women would commonly call the coil. But this is a special kind of coil that actually has the hormone progesterone, which is the hormone of pregnancy, put into it, and it releases it to the womb locally. Now think about it. When we are pregnant, we don't have periods. So it's simple, it's not rocket science. What it does is that it thins out the womb, lining of the womb, and these women don't bleed again when they have it. So you are treating what may be the problem for women. And again, just take a good history. A woman comes to you, she tells you she has the copper coil in and she has been bleeding heavily. You can't just jump to a hysterectomy at that point, because we know that the copper coil can cause some women to have very increased periods. So taking that copper coil out may be all she needs for treatment. And these are all alternative ways of managing the patient. Listen thoroughly to the patient. Manage the patient as a patient. For those who have pelvic floor prolapse, the weakness of the pelvic floor muscles, we can try pessaries in the first place. We can continue to do pelvic floor exercises where you pretend you are holding back wee-wee for a particular length of time, and you do that back and forth. You can do it anywhere. I'm doing one now, and nobody knows. That's the beauty of pelvic floor exercises, okay? And when you try all of these and they've not worked, then you can say, let's progress to the next stage and the big gun, which is the hysterectomy. For women who have heavy menstrual bleeding, you can consider what we call endometrial ablation. They've been what we call the first generation, second generation, third generation endometrial ablation. You have the use of warm water in a balloon, tema choice. You have the use of NovaSure, which is what we do these days. But the key is simple. The womb is a cup-shaped structure. You go in there and you burn the lining of the womb and it heals together by fibrosis. And that way the woman doesn't bleed anymore. It's about 80 to 90% success rate. And you can only tell if it's been successful about 6 months down the line. Then of course you have uterine artery embolization. And the way you think about this is, if I have a fibroid, it is not a cancer, but it acts like a benign tumor. So it's supplied by a lot of blood vessels. It's fed by estrogen. What do? If I go there and I plug its blood supply, it won't grow anymore. So uterine artery embolization is going to the blood vessels that feed the womb and actually occluding them. It's done by interventional radiologists under direct vision, and they know what they are doing. And it really helps in women as well who want to manage their symptoms conservatively. Then, of course, you have the myomectomy, where you remove the fibroids that may be in a woman, and this can be open, keyhole, or from down below in the womb, hysteroscopic resection. The same thing, you can remove polyps that may be inside the womb at hysteroscopy. And there's the magnetic resonance focused ultrasound treatment of fibroids. And these are not done in all centers right now in the UK or across the world, but you use high frequency ultrasound to actually disrupt the growth of the fibroid. And here is the laparoscopic excision as well, where keyhole, you go and you manage the woman keyhole wise. Is it a fibroid? You take it out and you grind it, what we call maceration, bring it out. Or is it endometriosis? You burn out the endometriosis. But what I'm trying to say is that you must first determine what is happening and what is best for the woman. And of course, counseling must follow all of this. Now, there are certain myths I just want us to dispel as I go along. Some say that it's a taboo. I was asking my mother, if a woman has had a hysterectomy in your culture, my mother is Nigerian, how do people perceive it? And she says, oh my God, it's a taboo to go back to one's maker without your whole body complete. These are social, cultural, and religious beliefs that would affect the health-seeking behavior and even the decision-making procedure with our Black and ethnic minority patients, and even patients from other cultures. There's always something unique. So we need to reassure them and explain to them that sometimes the creator or the maker may want you to be able to look after your children, give them a resounding quality of life before you come and meet them by dying from bleeding. And let them make these informed choices, but you don't need to force it on them. You just need to understand their idiosyncrasies. And there are those who say that many women are concerned that when you remove the cervix, it will lead to a loss of sexual function. This is false. There is no evidence to support that. And some will tell you that after a hysterectomy, you do not have sex until your scars are healed and the vaginal discharge has stopped, which is usually about 6 weeks. And that's true. So I'm just trying to bust some of the myths around hysterectomies. All women who have had a hysterectomy do not need cervical smears. Please, 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 this is false. It depends on the kind of hysterectomy you've had. Was it complete? Was it full? Was the neck of the womb taken? Was it a total hysterectomy? Whether it was done keyhole or open. If the neck of the womb was left behind for any reason at all, I mean the cervix, then please still go for your cervical smears as needed and don't be cut out. The other ones are women can sometimes go home after day one, after hysterectomy. What do we think? Do we think that women can go home a day after they've had their hysterectomy? Yes, the answer is yes. Especially when it's done laparoscopically. Yes, women can go home. And when there are no complications. And then they say you no longer need to use contraception to prevent pregnancy after a hysterectomy. That's true. But you do need barrier contraception to protect yourself against sexually transmitted infection. Hysterectomy can cause surgical menopause. That's true. If you had a total or radical hysterectomy and we removed all your ovaries, you will have the cessation of menses. Because the womb has been taken away, you may not know because you're not seeing the menses, you don't know if it's happened or not. But the hormonal pathway will be shut down, regardless of your age. So you may think about hormone replacement, and doctors like Dr. Diana Sante are good, the GPs, go to your GP. But I'll tell women who are outside of the UK, seek out a gynecologist, someone who knows what they are doing, because you must be reviewed and it must be prescribed by a doctor. The types of hysterectomies, what are the types? I've talked about them, but very quickly, it can be total, where everybody, all the friends and families of the womb are removed. And this can be open or it can be closed. It can be subtotal, where the main body of the womb is removed. Like some women, if they've had many cesarean sections and everything is stuck together and you want to remove their womb, you need to be safe, you need to keep them alive. You take out the body, which you can take out of the womb, but the neck of the womb may be very plastered, so you leave it be. Then it can be total bilateral salpingo-oophorectomy. That's just a big word. It means we are taking out the womb and the tubes and the ovaries. And it can be radical, especially in cancer, where we'll go and take out some of the vagina, the lymph nodes, and anything near it. And I've told you that it can be done keyhole, it can be done from the vagina down below, it can be done abdominally, but the key to deciding how you are going to do a hysterectomy for a patient is the size of the womb, what the pathology is. If it's a cancer, you don't want things spilling everywhere. If it's an advanced cancer, you just open up after an MDT meeting, of course, after this has been discussed and decisions are taken. So patient selection is key. You can't go and take a womb that has a 30-week fibroid out and say you want to take it out from down the vagina. How will it come out? So you need to, and we need to know that there are complications that can happen with hysterectomy. And these are the general anesthetic problems. Some patients can react to what you use to take away pain and put them to sleep. Bleeding after that, damage to the waterworks, the ureters, the bladder, and then infection, of course. Blood clots can happen, vaginal problems, where sometimes you close up, especially from down below, and the vagina is short and tightened, and the women start complaining that sex is now painful. Sometimes you can have the ovaries, they've been taken away, and then they just don't, there's nothing to give the woman estrogen anymore. They are tilted into early menopause. And let us not forget the psychological and sociocultural negations. I was in a church recently and somebody was talking about heavy menstrual bleeding. And then the person said, to the glory of God, the bleeding had stopped when she saw the doctors. But what she did not say, which she could have added there to help the health-seeking behavior of the congregation, is that I had to have a hysterectomy for my own case, because people relate very well when they've seen someone in their communities who have had a hysterectomy. Then they start to think, okay, it's not a taboo, especially in those cultures where you are considered incomplete, or some will even say you are a man now that you've had a hysterectomy. So you need to have a hysterectomy. It's important to be fit. You stop smoking, eat healthy, regular balanced diet, lose weight, please. Avoid evening food, have a whole diet overhaul, make it easier for your doctors. I'm just imagining the struggle I have to struggle sometimes, all because of just the patient's size and the fatty deposits. And then we need to counsel our patients as well. You must be prepared psychologically, socially, otherwise, economically. You're going to be off work. Are you working for yourself? What kind of sick leave are you going to take? How do you prepare your children? Who's going to help? Depending on the kind of hysterectomy you have. Some people may be out for even 2 months or 3 if there have been complications. Now, what is the role of men in all of this talk? Because after all, men don't have wombs. Well, on a good day, they don't have wombs, except we are beginning to transplant to some. What is their role? And I'll tell you that men are very involved. They have a huge role. Because if you're a man, you have a sister, you have a mother, you have a wife, you have daughters. And this is a major, major topic. We need to sit down with them and discuss with them. Look at the information they've gotten from their doctors and help them in the decision-making processes. Sometimes, let me give a classical example. A woman has not had a child, but she's bleeding heavily, and we find out that she has a fibroid. that is pressing on her bladder and occluding urine from even flowing through her waterworks, like the ureters, and the kidney is becoming damaged. And as the husband, you are still telling her that you need a biological child. No. You can sit down at that point and begin to discuss alternatives. You can sit down at that point and think about adoption. You can sit down and think about surrogacy. So men are very much involved. If your mother is bleeding heavily and she's becoming anemic, I'm sure the men in the house want to seek the reasons why and lend a hand to their mother. The same thing will happen with the wife and obviously with the daughter. And for all of us here, wherever we are, we must lend a helping hand and share information, which is why once again, I commend CATHIP for what they are doing. And I will tell you my own personal journey about a hysterectomy. And you can see pictures there because I'm looking at it and I'm telling you this. And I think this is one of the best ways to make it sink in. You can see me as the healthcare provider and you can see me as the patient. And obviously you can see me in my everyday glamour mode as the author, the educational speaker, and all of that. But I have had a hysterectomy. And why did I have a hysterectomy? Why are you instead of my abdomen? And yet I'm telling you about a hysterectomy because I think my case was very unique. It's a case that has been presented at the Royal College Congress in as far as Australia. So what happened was that I had fibroids. Remember, I told you, fibroid is the friend of the African woman. But I didn't have heavy bleeding. So this is another example to show you that it doesn't often present in the same classical way in everybody. What did I have? I have a situation where I started coughing. I started feeling very unwell and people thought it was asthma, not knowing the fibroid was growing. And they gave me some medication. They tried the medical route, but it didn't work. This fibroid kept growing. And one day I started leaking fluid from my nose. And my husband, bless him, who is a consultant neurosurgeon, came in, had a look at me. Everybody had been seeing me. I've been moving around, seeing myself, and said, no, I think this is a CSF leak. That means the water that bathes my brain and my spinal cord was leaking out of my nose. And I just thought it was cold and catarrh. I got all the antihistamine, all the Vicks spray, all the everything, imagine. And then he took me to the A&E. And lo and behold, got a long story short, when we got to the A&E, yes, it was the water around my spinal cord and that bathes my brain, the CSF that was leaking. The question was why? I'd been treated for asthma. They were wondering why was my heart enlarging? And then the answer came to us in hindsight. I had a 30-week size fibroid, and that fibroid was pressing on my pelvic veins. So I started having a thickening of my blood, and that was beginning to cause clots to shower around my lungs. So all the while my GP was thinking I had asthma, I was having what we call PEs, which was blood clots in the lungs. And that coughing made me to rip my dura at a place called around the cribriform plate of ethmoid that connects the nose and everything. And then that fluid started leaking out. So I was on my way to just dying, just dropping down and dying from infection, from meningitis. Imagine. But that man saved my life. And so the neurosurgeons had to operate very quickly. But when I got to the gynecologist, because they had to send me as an emergency to the gynecologist, if not, it will happen again. The first question she asked me, because I was young, do you have children? And I said, yes, I have 2. And I gave birth for a medical doctor quite early. And she was like, thank goodness. Because it was clear to all of us at that point that the only solution was to take out my womb entirely because I had a fibroid the size of a 30-week-old baby in the womb. And I've had my hysterectomy since then. I didn't go to work in the whole of 2017 because I had a brain operation, what they call a craniotomy, and a lateral graft, facial lateral graft, to plug that leakage from the dura where it had torn. And then, of course, they had to do the hysterectomy as well. But here I am today, and those battle scars of life are with me and telling my story. But you can see that my hysterectomy was very necessary. There was no other alternative. So on this note of my own personal life story, I'll tell you that I still enjoy sex. After the hysterectomy, I lost weight because I had lost I'm extra 30. I'm sure about 3 kg. I've lost it. I became more active. Yes, I got tilted. Well, I went into an early menopause. Yes, but the advantage is that I don't have a womb, so I'm just able to have my HRTs and carry on. So, in a nutshell, do you need that hysterectomy? Some of us may not. Think of the alternatives and think as a healthcare provider of your patient as a human being and decide what is best for them. Thank you very much, everybody. I will take questions.
Thank you so much. Thank you. This is such a power-packed presentation. And that personal story that you shared at the end, Lorretta, it's just something you cannot conceive. But when you were telling your story, I sat here and I thought, this is a miracle that you are alive, and we thank God for your life. But also, it's so unusual, isn't it? It's not the normal thing that you'd expect, that someone with a fibroid will end up with such complications leaking CSF. So please, let's not have the fear put in us that that's the norm. This woman is a miracle woman. God has saved her life. But clearly we get the point that most people would have different presentations, and we are all different. And I like the way you gave such a simple presentation, something we can all understand. You broke it down. You just dispelled all the myths that we commonly have. And the one that you talked about, not going back to your maker without your uterus, just made me laugh silently as I was sat here. So thank you so much for that, Dr. Lorretta Uduari Ogboro. We will be coming to questions in a short while, and there are already quite a few questions in there. But we also have someone who's taken her time out to come and share her lived experience with us. This lady is also a remarkable lady. She's an entrepreneur, she's a therapist, she's an author, she's also written a book. But most importantly, she's had a hysterectomy herself, and she wants to share her journey with us. So in the next 5 minutes, it's my honor to introduce Veronica Eubanks. Miss Veronica Eubanks. V, please take over and tell us your story. I know that time is fast spent, so if we can be very brief and straight to the point, that would help, because we're eager to take all those questions that have come. Thank you so much, V. Over to you.
Right. Good morning, everybody, or wherever you are in the world. Greetings. So I'm Veronica Eubanks, and I had a hysterectomy about 12 years ago. I'm 61 now. And did I need the hysterectomy? Well, I was at work on a particular day, and I stood up. I had been bleeding heavily for many years. I'd always had painful periods, but the bleeding as the years went on, and just may I add, I have 4 children, so I have four sons at the time, and the bleeding just seemed to get worse. And on a particular day at work, I had a horrible accident. It looked awful, right? Just as well, I could maintain, well, I couldn't really maintain my dignity, but I had a work colleague who assisted me to go and get cleaned up and help me out with some extra bits and pieces to put on and so on. I went to the doctor because at that stage, I believed enough was enough. I'd been padding up myself, Tampax and pads, change of clothes and all sorts of things. And I went to the GP, and the GP said, well, okay. And as the Dr. Lorretta said, Mirena coil. He recommended the Mirena coil, and I had that fitted quite soon. I think the following week I had my appointment, and I had the Mirena coil fitted in the surgery with the nurse assisting the doctor. That didn't work because the Mirena coil disappeared. Within a fortnight, that had gone. But just to wrap the story up, yes, I did need a hysterectomy because when I had further investigations, it was found that I had a 15-week size fetus, 15-week fetus-sized uterus. And it had been pressing on my veins. My stomach had distended. Over the years, my stomach had got bigger. But you know what? I just thought that's what happens as you start to age. Your stomach will enlarge. But in the summer, my feet also became swollen and my toes looked like little sausages. I ended up just wearing sandals because I just couldn't wear proper shoes. So the swollen stomach, the swollen feet, just like someone had poured fluid in both of my feet and lower legs. And in the end, processes, investigations, a hysterectomy was what was suggested. I had two options, the uterine atrial embolization or a hysterectomy of some kind, because I was told that depending on the size of it, because it's quite large, it's very unlikely that they would do a vaginal, but they would see. In the end, I ended up having a partial hysterectomy, i.e. just the uterus and just the uterus and the cervix was removed. The ovaries and I believe the tubes, because something happened later, the tubes were left. So that was my story. And yes, I was one that definitely needed a hysterectomy. But there were lots of questions. And just to add, some of the myths, I don't feel less of a woman. Sex was great afterwards. Once I healed, I was able to just get on with my life. And I think I looked fantastic after I had my hysterectomy, after I, fully healed. I think my body looked fantastic. Some of the dresses that I was struggling to get into because of this bigger stomach, I could get back in. So it's brilliant. It was the best thing for me. I just skipped past those aisles with those big pads that I used to have to buy, packet loads. It's fantastic, absolutely fantastic. So anyone here listening, those myths that the doctor went through, it's not true. It's definitely not true. All right. So I'm glad. Thank you for the invitation. CAHN. Thank you so much for inviting me along to this hour. And I'm happy to share. And now I have a book that I wrote because I kept a journal during my journey. I kept a journal and I found it recently and I have published it. And this is it, the Hysterectomy Chronicle. It's not a thick book, but my journal of everything is in here. All right. So if you want to get that, that's on Amazon. I'm also having a book launch tomorrow in Luton. I'll probably share the link in the chat if I'm allowed to, if I have permission. But if you are going to have that operation, if you are having a hysterectomy of some kind, you will need help. You will definitely need some assistance, okay? And it's a biggie, depending on which one you have. It's a massive operation. So thank you again for listening, everybody.
Oh, thank you so much, Bea. Thank you. That's a lovely story that you've shared, but also very personal and just very honest as well. And by the way, I must say you look great at 61. So certainly that hysterectomy hasn't demeaned you in any way.
No way.
It's interesting, isn't it, that both our speakers today have written books as well. Lorretta, you've got a book as well, haven't you?
Yes.
What's it called? My Father's Daughter, did you say?
Yeah, I've got 2 books on Amazon.
Okay.
My Father's Daughter is the first one. It's the chronicle of a father mentoring the child and preparing them for the world, which everyone here will find very useful. And there's another one, Heart Webs, which is some sort of esoteric romance, and on Amazon worldwide.
Ooh. Please, can we have can we have both those put in the chat box, please? So V, please put yours in the chat box and Dr. Lorretta as well. But this is so great, isn't it? Because we've got real life people telling us their stories. Heather, I love your hair, by the way, telling us their stories about what they've been through and how it's impacted them, and just being honest and frank. And that's what we need. You just want someone who you can see, who you can touch, who you can feel, who you can identify with, who's been through that same thing that you need to know about or talk about to share their story. So this is so lovely. Right, we've got millions of questions, so let's fire away. First of all, I mean, I'm probably going to lump up the questions about fibroids together. So Empress Divine has asked a question about fibroids, but there are a few others about fibroids. Why are fibroids so common and how do we get rid of them? And just to add on to that question for you, Dr. Lorretta, not just how do we get rid of them, but is there anything we can do to prevent them? I know you've said this, but please, it's so important that we get this before we leave here. So if we leave with nothing at all, we want to know. Do we know? Can you tell us, please?
Yes, I'll be very honest. First and foremost, fibroid is the gift to the African woman. I said that before. It's just us. Some people have attributed it to our diet, but there's not much you can do about that. But knowledge is power. While 3 out of 5 of us, we have fibroids in our lifetime, it will be probably 1 or 2 of Caucasian women. And let's not be too alarmed. Fibroid still remains one of the most common conditions women worldwide anyway will have in their lifetime. Now, understanding how it works is more important for you to manage if you've got fibroids. There is the common saying when I was in medical school that a womb that does not carry children will carry a fibroid. The simple reason is this: fibroid is fed mostly by the hormone of the non-pregnant woman, which is estrogen. And if we don't get pregnant for a long time, it just grows. I am an example. When I was having my first child, I had tiny fibroids. But the gap between my first and second child was 5 years. So the fibroid grew. And I'm a very active person doing my exercises. So my tummy was flat. But another 10 years after my second child, and the fibroid grew even more, and people would not know because my tummy was really flat. So my own muscles, my working out was pushing it right back on my pelvic vessels. And this is really rare. Everybody doesn't come down. In fact, the commonest symptom of fibroid is no symptom. So what do I mean? A lot of us are walking about feeling cool, really chill. We've got fibroids, but it's causing us no problem. So we don't know it's there. Now, if you then think about it, it simply means that anything that takes away that hormone will make the fibroid go away. So if you have a fibroid at say 50 and your mother was maybe menopausal at say 52 or 49, you may not, depending on the size and the disruption to your quality of life, you may not need to do anything about it. This is why I'm saying understanding how, because you are going to go into the change anyway. And when you go into the change, estrogen, which is produced by the ovaries, who then go asleep, will not be in high circulation anymore, because the change or the menopause is when our ovaries go to sleep. They're tired. They came with us and started working when we were maybe 13 or 12, you know. So they've given her all their eggs. And they're like, oh, I'm tired. No matter how much the brain flogs me now, I'm not going to respond. So you then find that after the change, fibroids begin to shrink. I have my godmother who had fibroids, was bleeding heavily, but she was 50. She was considering a hysterectomy, and the doctor said, can you just manage with GNH analogs, those drugs I talked about that cause the artificial menopause? And then we give you only 3 cycles, because we can't use those drugs too forever. We need to protect the bones and the lining of the womb as well. So he gave her that, he put in a Mirena, and by about 50, she was menopausal. So she didn't need a hysterectomy, and that fibroid was managed, okay? Now, there are women who, in terms of prevention that Dr. Asante has asked, I think for us as African women, we must deal with our weight. Our weight, our weight, our weight. And the theory is that carbohydrate-rich food can actually increase your risk of having fibroids. We must then also educate our daughters, because we don't tend to speak about these things. We don't speak about sex, we don't speak about relationships, in our Afro-Caribbean culture, and I don't know why. We must begin to educate our daughters. Like right now, I'm telling my daughter, if you know you want to have children, don't start selecting men that come your way. You're looking for shadow driving, tongue speaking, handsome, dark, tall brother. You have to be realistic and know that the ideal age for conception for women, ideally by nature, is between the age of 18 and 25 for a reason. Because when you delay it, you are going to start having all of these things manifesting. So our social-cultural milieu is very important. Seek out that man you want to marry and marry on time. I know some of us will say it's when God brings the husband. But then sometimes, because we don't also know what we are doing to ourselves, we delay potential husbands on the altar of frivolities. Okay? And
That's probably a
decisions.
topic, another book in the making, I guess.
So lose weight, a healthy diet, fruits and vegetables, keep exercising, water. And if you have a fibroid operation, if your doctors do not tell you, please, I will tell you today, try and get pregnant within at least a year of that surgery. If not, it's just going to come back. Now, when we get pregnant, what happens? The fibroids have a lot of estrogen in circulation. So they really grow, they're happy, and then they outgrow their blood supply. And they start to degenerate. So for women listening to me in the reproductive age, if you have fibroids, mentally prepare that you may have what we call red degeneration pain. It stops around about 30 weeks for some women. It carries on for some women, but it's a good thing because the fibroid is going to get smaller after that pregnancy. So to sum up, managing fibroids is multi-pronged. It depends on, and then preventing it is adhering to the rules of health living and managing the diseases of choice. But in some women, there's nothing you do anyway. It just comes, and you can't kill yourself.
Thank you for that. So things that we probably cannot do anything about, but the things that we can do something about, like watching our weight, our diet, exercising, all of that, we should. But I think it's a key point you raised, that knowing the fact that we have an increased propensity towards having them is useful, because when you know what you're fighting against, or when you know what you're dealing with, then you are better equipped to deal with it. So really the knowledge that it's a higher incidence among Afro-Caribbean women is useful information, and we can work with that. Just on the same thread of fibroids, now just to prompt you, Lorretta, we have lots of questions. So what we'll try and do is we'll try and make the answers brief, but I might try and merge some of the questions as well if they have a similar theme, so we can try and get as much as possible. So just on the same theme of fibroids, the commonest symptom you've said is most of us are walking around with fibroids. We don't even know about it because we have no symptoms. You've talked about bleeding. Apart from the bleeding, I'm just wanting you to hammer on this a bit, because you had pressure symptoms. Sister V had pressure symptoms. What are some of the pressure symptoms that fibroids can cause? So not necessarily bleeding, very briefly, what else can present that will make people?
So to make it simple, let's just think that we have a balloon, and in that balloon, we have put a piece of small stone on top of it. That balloon was filled with water. What happens? You are going to have the water wanting to leak out from somewhere. So one of the key pressure symptoms, and you're going to have pain where it's depressed. So one of the key pressure symptoms is that if the weight is a lot, that means if it's that big, you have pain, depending on where it is. You then maybe have you feel like you want to wee all the time because it's pressing on the bladder. And then you go and you make only little wee, not much, but you feel like you've not finished weeing. So feeling of incomplete voiding, you leak urine sometimes because that weight is there as well. And then there can be painful intercourse depending on where it is as well, pressure symptoms. And of course, you just have a woman who presented once, just like V, her legs were swollen. The fibroid was sessile, that means it was mobile. and it was pressing on the waterworks, the ureters, and the kidney was not able to get the wee-wee to flow away. So she was really having some sort of chronic kidney failure. So those are some of the pressure symptoms as well. So pain can be there, but classically, please, I want us to get it right. Fibroids do not necessarily cause pain, but pain can be one of the pressure symptoms. Pain at rest, pain when moving, pain when having intercourse, especially deep-seated pain, leaking urine, and feeling of incomplete voiding. And some women can even be constipated if you have it on the posterior aspect of the womb and it's pressing against the uterus. Because don't forget, I told you that the womb is surrounded by all its relatives, friends, brothers and sisters, and acquaintances. And these are the bladder in front, the rectum, and at the back. The bowels are all moving. So these are some of the other pressure symptoms. You can add some, Dr. Asante, if you remember some that I have missed out.
Thank you so much. That's really useful because some people might have some of these symptoms, isn't it? And they will present with that. So someone would like to know, Frances would like to know, does the Mirena coil increase blood pressure? Does it increase blood pressure? And the second question for you, sorry, I'm going to load you a bit. How can one be diagnosed with endometriosis? Can it affect young girls? So if you can take those two for us, please.
So Frances McBride, the Mirena is, I explained it, is a T-shaped coil. I used to have a model here. It's a T-shaped coil, yeah, that sits inside of the womb, and it is impregnated with the hormone of pregnancy called progesterone. Specifically, the one in the Mirena, man-made one, is called levonorgestrel. So what it does is that when it's sitting in that womb, it releases the hormone at a measured pace every day, and that thins out the lining of the womb. In theory, its effect is local, so it should not raise blood pressure, and it rarely does. Rarely does. However, there are a few women, very few, less than 1% of population, who are extremely progesterone sensitive, and they could have some effects from progesteronic effects from Mirena, but it's very few. And I'm one of those few. I had Mirena migraine, which is very rare complication, very rare with a Mirena. And I've not seen, I think in all of my practice, I have not seen a woman with raised blood pressure from having the Mirena. So it's a theoretical, very slim risk. So you can have the Mirena if it's suitable for you, if it can be inserted. Because another thing is there space to put it, or is the blood just coming and washing it out? Can we still hear me? My internet
we can, yes, we can hear you.
Now, moving on to the next question about endometriosis. Endometriosis is one of the most poorly diagnosed conditions in women. Sometimes women spend an average, and this is evidence-based information I'm giving you from the ROCOG, from NICE, and from studies in medical journals. Women spend an average of 5 to 7 years in the community, moving from doctor to doctor, even in the United Kingdom, because of pain from endometriosis. How much more in resource-poor countries where awareness is low? And why does this happen? It is because when these women start their periods, most of them have heavy periods. And especially in us, Afro-Caribbean people or Black ethnic minorities, your mom will tell you your period is painful, just get on with it. I'm sure, Dr. Asante, you've heard that before from your patients when the diagnosis is eventually made. Oh, yes, what's your problem? Because you are having period. Go and do something. You know, but there are people whose periods are debilitating. It causes pain for them. They can't even go to work at those times. They have poor quality of life. And this is because the lining of the womb, which should be inside a cup-like structure, is now maybe in a tube or in an ovary that is a finite space. That means it's a fixed space. So every month since you started having periods or since it started, you are bleeding into that tiny space. And let's not forget that there are extrapelvic site endometriosis, even the palm. There are women who have the lining of the womb on their palm, and every time they are having period, they are in pain. Their hand is painful and they don't know why. Or those who have had cesarean scars and they have cesarean scar line endometriosis. And it is very, very painful because the lining of the womb has ceded to the cesarean scar line. So how do you make a diagnosis? You must take a careful history. Listen to your patient. Give a menstrual diary that correlates with that pain. So when you're having your period, you mark it. When am I having pain? And when you come back with that diary after 3 months, it just shows a picture of period pain. Period pain. And some women say, oh, I never knew this. I never took note of this. And then you can then go have an ultrasound scan as well. Sometimes we can see endometriomas when it is collected within the ovary, or we can see some adhesions in some places. But when it is in the muscle of the womb, sometimes you don't see anything. And that is adenomyosis, when it is in the muscle of the womb. So gold standard, you go in, if the history is very strong, you go and have a look keyhole, and that's called diagnostic laparoscopy, sorry. You have a look keyhole. However, I trained one of the authorities in breathing at the time, where you can do a test of cure with GnRH analog. And this is, you create an artificial menopause with this medication. If that pain goes away, or even with contraceptive pills, or even with the depot, because you're not having periods at that time, if that pain goes away, it is a pointer that that is endometriosis, and that's a test of cure. So you can treat it how best the patient, if a patient is looking for children, you cannot give some medications like the GnRH analog at that time. But if the patient is, depending on the age, if it's a young girl, you can give combined oral contraceptive pills. You can give depot. You can insert the Mirena. It can reduce the pain. And endometriosis also comes with pain during sexual intercourse, deep dyspareunia. That's pain during intercourse. And the women and the men, this is where you come in again. Your wife is always complaining of pain during sex. Don't think she's just making it up. Sit down with her and have the discussions. I hope I've answered some of the questions. I don't want to stay too long.
You have indeed. And it is a very big problem because people really struggle with endometriosis. And as you rightly said, some people have been back and forth for years, struggling for years before they finally get a diagnosis. And so it is an area that's important for us to sort of know about. I know we've had sessions on it, and we'll probably have a special session on it again in future, but thank you so much for that, because it's really important. Now, just very briefly, maybe a yes or no to this, or I don't know if there's anything like that in medicine, but anyway, can someone develop endometriosis even when you haven't had a period for over a year? Is that something, so that Abby is asking, if you haven't had a period for over a year, can you still develop? So
Abby, I need to be careful answering this question. You've not had a period for over a year. Why didn't you have a period? Were you pregnant? Are you around the time of the change? We need to know the big picture, because I can't just say yes or no to that.
No.
Because endometriosis, some people are born with it, some people may acquire along the way. There's the retrograde theory of menstruation, all sorts of theories. No firmly affirmed one that this is what causes it. So if you take my number, I think you can contact me or even Dr. Asante, and then we can have a conversation about that. But off the top of my head, if you've not had a period, you may have, if you've always had it, you may have residual endometriosis. Because if you imagine, if that blood has been collecting there over the years, and you've not had a period, maybe you are going into the change, for instance, there can still be some residual blood there that would have mobilized inflammatory reactions to that place. And things may now then be stuck together. Unfortunately, some women even have endometriosis on their bowels.
Yeah.
So even if they've not had periods for a year, there has been inflammation, everything is frozen. And those bands and adhesions and all of those things can keep causing pain down the line. Sometimes you may just need them releasing.
Yeah.
I hope that
Okay.
answers the question.
Yeah, thank you. And I think that was a bit unfair to say yes or no, to ask you to say that. It's a bit of a tricky one. So Abby, you can please send your send an email to health@can.org.uk, and then we can contact you and delve into that a bit deeper. I guess that there are lots of things that need to be unpicked to give you the right answer on that. Cecilia, you said you've had a hysterectomy about 3 weeks ago. I hope you're recovering well. You had your ovaries remained intact, so a partial hysterectomy. Good, and all the best to you. So someone is also saying, I have multiple fibroids, some were very big ones, with a very big uterus, and sorry, it's flown away.
I think that's still Celia.
That's still Cecilia.
Yes. Yeah,
Yes.
Cecilia is just describing
Yes.
how she went to ICU with the BP and tachycardia. Well done, Cecilia. You are a survivor.
You are.
You
indeed.
definitely needed the hysterectomy.
Yes.
But also, we must emphasize that there are some women who the alternative managements could cater for.
Yes, and the alternative managements are important, because you talked about that individualized care, didn't you? Where it's so important to speak to the patient, know their specific story, and then tailor the management. I have a story I wanted to share, but because of time, I'll leave it and see, because I know we're really behind time here. Anyway, Bosidi or Bosidi says, hi, thanks for the presentation. After having children, would the uterus still remain in the pelvis? So I guess it's going back to your initial diagram about the location of the, so please tell us, after having children.
We are going back to ancient times.
Yeah.
The uterus is in the pelvis. It is fixed in the pelvis. It never migrates. It doesn't go anywhere. When you are pregnant, yes, it can go up to accommodate the baby, but once baby is born, it is a very beautiful creation of nature and God. It contracts back down into the pelvis. Except it's distended by something else like fibroids or something, then it goes back up. But it's always there. It's firmly fixed. There's what we call the uterosacral ligaments that support the uterus. I don't want to go into all that big jargon. Just, yes, it's always in the pelvis.
So it's always in the pelvis. That is permanent abode. Thank you. Dr. Lorretta, do you do any private work? Can you share the details of that if you do? Because people want to know if they can contact you regarding private consultations.
All right, we'll talk about that outside of public space. Yeah, emails.
And then we can share details in due course if we've got them. Thank you. So for me, Claudette says, for me, I have urinary prolapse. I have been waiting to see a gynecologist for the last 2 months. I've asked for a hysterectomy, but they wouldn't give me, I'm still here waiting in pain. So basically she's got a uterine prolapse.
Oh, uterine prolapse. I've been waiting to see the gynecologist for the last 2 months, and I've asked for a hysterectomy, but they won't give me. I'm still waiting in pain. I think, Claudette, I can't just say your doctors are wrong or right. I need the full picture. How old are you? Have you completed your family size? Is it, if you have a uterine prolapse, how bad is the prolapse? Because it's a big surgery. It's big for the patient, just the same way it's big for the doctors, the nurses. The MDT is big for us as well. It consumes the resources of the NHS, which is our collective commonwealth. So I think that what you can do, and this, I'm saying this to all of us, especially us in the Black Afro-Caribbean societies, culturally, we don't like to bother people, and that's just our culture. But I think we should step out from that, because you can get your consultant's name, you can get the secretary, and you can just ring them up and very nicely say, I'm still waiting. What's happening with my care pathway? And this, I find in my own, because I'm a researcher as well, in my own small way, that other people do this more than us. And sometimes the baby who cries and raises up the hand is the one that people are going to take up anyway and lift and cuddle. So that's why the stresses on the NHS I want us to be a bit more
Proactive.
about our care and our health-seeking behavior. And it's not like we don't want to be. I think it's just that cultural orientation where you say, oh, I don't want to bother people in authority. They are very busy. It's our own way of being considerate. But at the end of the day, please pick up the phone, speak to the secretaries nicely, Claudette, and ask them what's happening. I'm sure your doctors have a good reason, either waiting list acuity, or that you don't need it here, depending on your age, depending if you had children, depending on what you told them, why they are delaying.
Yeah, thank you. Thank you. And that's why these CATHIP health hours and CAHN sessions are great, because we get to know a lot more about these things, and we're filled with a bit more confidence to ask the right questions, isn't it? Because as you rightly said, culturally, we're a bit laid back and we feel we don't want to bother people. But sometimes when you know that you can ask questions, or you can follow things up, or you can check on things, we feel a bit more equipped. So thank you so much for equipping us today. Another flurry of questions for you, Lorretta. So someone did ask about adenomyosis and said, could you touch a bit more on it? And I know you've said that adenomyosis is basically the endometrial tissue in the muscle, of the uterus. So we'll move on to another theme so that other people can benefit.
I can use this as an example. If you consider this to be the womb, it's upside down anyway. Now, when you have endometriosis anywhere else outside here, it's endometriosis. But when you have it within this muscle, when it's here in this place, then it's adenomyosis. It's within the muscle of the womb. And somebody is asking me with respect to adenomyosis, Samsung SMA8.
Yeah, Samsung.
You are saying that can the Mirena coil fitted help with adenomyosis? Yes, it can help take away your pain of adenomyosis, depending on the severity.
Thank you for that. So that was the next one as well. And then Lande is also asking, passing on someone's question. I have been told I have a bulky uterus. Can you explain what that means? So when we hear someone has a bulky uterus, or you have an ultrasound scan and they say bulky uterus, please, what does that mean? Can you simplify it for us?
Okay, so the normal sized uterus is pear-shaped and the size of an almond fruit. So it's really small. So if I examine the woman who was not pregnant and is a young girl and has not had children, I shouldn't feel anything much when I do a bimanual examination. However, words like bulky come when they are telling you that it's a bit bigger than normal. And I sometimes query that use of that word, because it's just like, well, being loosely thrown around. Why don't you just measure it and tell me what the actual measurements are like? So it's not a diagnosis or a death sentence. It's just telling us that the womb is a bit bigger. And what can make the womb a bit bigger and cause no problem? If you've had many children, you've used the womb a bit more than every other person, it just gets a bit bigger. If you have tiny fibroids scattered everywhere, it can get a bit bigger. And it may just be may just be special and just a bit bigger. But when you see the word bulky, please don't think it's a death sentence. Because somebody called me once and said, oh, my womb is bulky. And no, just means a bit bigger. But then again, it can be a sign that there's adenomyosis. If the muscle of the womb, you've been having periods into it for many years, it can also be a sign of that, or nothing.
Thank you. Thanks for that as well. Joe, you'd want to unmute. I'll come to you in a minute. Get ready. I'll let you unmute in a minute. I'll just go through a few more questions and then we'll come to that. So can the Mirena increase the risk of breast cancer in some people?
No.
Okay, so no, thank you for that. Again, lots of thanks and feedback for you, Dr. Lorretta. Thank you for your presentation, very useful, timely and all of that. And the common examples that you used as well. And Veronica as well, thank you for sharing yours as well. Right, so the other question is, I think we're also waiting for your number, if we can get it, or if not, we can probably get the information later. Joe, would you like to unmute yourself? And please, okay. I've had some feedback. Joe's no longer on the call. That's fair enough. We'll carry on. when someone has had a hysterectomy, Dr. Lorretta, what can they expect after the hysterectomy? So we've heard the good sides, you felt great, sex was good, hopefully whatever led you to have the hysterectomy has been sorted out. We know that if you did have a total hysterectomy, then you have been plunged into a surgical menopause. But in terms of practicality, what can we expect? When can I expect to go back to work? Would I be limited in doing anything? What can it affect? What are the practical things, the things that you don't actually get told, or maybe you get told and it washes over your head? What can someone going to have a hysterectomy actually expect after the procedure?
Okay, so depending on what kind of hysterectomy we've had, was it open, was it closed? Just a second, sorry, yeah. So was it open, was it closed, was it keyhole? If it was open, obviously recovery takes longer if it was open. And that's about 6 to 8 weeks, we are told. So you expect a cut in the beginning line where your C-section is done. Or in very, very big cases of fibroids, and if they perceive that you have adhesions, maybe previous C-sections, they may actually do an up and down incision. Or if the hysterectomy is being done because of cancers and you don't want anything to spill, you just want to get everything out, you need access. It's all about access. Then it can also be a top bottom. And when I say top bottom, just from under the umbilicus up to the suprapubic point where your panties would normally lie. So you expect a cut like that. If it's keyhole, hey ho, you have tiny holes on your tummy and that can heal quicker. I told you that women can even go home a day after a laparoscopic hysterectomy. But then, let's be careful. Every woman heals differently, and healing has a psychological component as well. Plus, it also depends on how much support are the people around giving to this individual. Do you have a supportive husband, supportive family, supportive wife, supportive mom, dad? All of those things count. But overall, you will have pain. You will have pain. And I often tell women, roll up a towel or have a little cushion pillow and apply that to your tummy so that when you laugh or when you cough, there's counter pressure. That helps reduce the pain and that helps prevent hernias and it helps with the healing. Then you will likely have discharge from down below. In the early days, it will be a bit bloody, frank red blood, and then it settles to dark altered blood. And it should not have a foul smell. If you begin to have a foul smelling discharge or blood within 6 weeks of having a hysterectomy, see your GP or go to A&E. It may be a sign of infection or a collection. If you have intense pain after your hysterectomy, immediately after, it may be that you are bleeding again. So there's always a small chance after a hysterectomy of going back to theater. A small chance is there because some women may bleed again. There's also the small chance after a hysterectomy of having what we call an ileus, where the bowels are not really working. They are wondering what should we do because they were touched at that procedure. Or even sometimes you just have an obstruction. I had an ileus after my hysterectomy. I didn't know that was how it was. I didn't know that was what patients had been describing all my years. Couldn't put my hands down. It was just like this. I couldn't breathe. I couldn't eat. My tummy was distended. I was beginning to vomit until they put an NG tube down. And that was when I knew that, oh God, I'm still alive. So name it, I had it. And I think people should be kind to themselves. You should start walking around quickly. You want that. So to avoid blood clots, you'll be giving blood thinners as well, because it's still a big surgery, but we don't want you to overdo things. And then there's the rule on driving. Speak to your GP. I think you're not allowed to drive for about 6 weeks after. I don't know if that has changed, Dr. Asante. So pain, a bit of bleeding, and of course discharge. And then it's interesting because I see many women coming back and asking me, when can I have sex after a hysterectomy? That is one big question they all come to ask. And I even see some men carrying bag and coming to the hospital. Have you had sex now? And I will tell you the answer is, when you are healed properly. When are you healed properly? That's in your head. That's in you. That's for you to decide. Because as a woman, you may just not feel up to it. Even though I tell you, oh, the vault is healed, the stitches are gone. These days we use dissolvable sutures, so there are no stitches to go and take out most times. Some people still use clips if they do an up and down one, and you may need to take that out. But here in this country, followed up by your GP or the district nurses. But with respect to sex, please let that come from you when you are ready. Don't be fixated on numbers. Your mind must heal. You must be ready to go. And for men, this is time to be kind to your wife after a hysterectomy. You must improve on foreplay. This is not the time you just come and say, oh, turn the thing and let me come in. No, please, you have to be kind. You need to explore using water-based lubricants. I don't want to call names because we are on air and I'm not promoting any particular brand, but water-based lubricants would help. And a bit of patience with everything. This is the time you ask your wife and have those conversations. Where is her G-spot? What turns her on? This is not the time to start looking for a new wife or a side chick. I'll say that now, because your turn will come. That's what men don't understand. You will have your issues down the line as well. And believe you me, those side chicks will abandon you. It is these women with all their hysterectomy scars and the rest that will stay with you.
And you get lots of smiles and smiley faces for those. Hitting that nail on the head. Right, that's really interesting. Thank you so much. What can we say? It's been such an interesting discussion. And V, thanks for adding in as well, because V has also added in a bit of her experience as well. She said you also be offered a phased return to work, or in some cases people will obviously be signed off work for those initial 4 to 6 weeks, depending on which kind of procedure.
You're entitled to your sick leave in the UK, but you're in other countries, you have to find out what you are entitled to. Well done, V. Yes, your body and mind must be healed. Yes,
absolutely. Yeah, so I think we would have to draw the curtain on this very interesting discussion, which I wish could just carry on, but we've suddenly realized it's 12:38 and it's gone on for a long time. And I know that people have really busy weekends, and I know that as a nation, and we're mourning as well the loss of our dear Queen as well. So there's a lot that's going on, and we value everybody's time just coming out today to have this really important discussion. Dr. Lorretta, what can we say? It's been so great. People are clapping, thumbs up, and all sorts of messages. You've made it so lively, so enjoyable, and you've shared your story as well. She's got books written. Let's check those out. Sister V, Ebanks has her books as well. Sister Cecilia shared her own experience about hysterectomy, and she's demystified what we hear about hysterectomy. So please, we are informed. Let's ask the questions. Let's find out. If you're having these symptoms you're not sure of, get the help you need. If you're being passed from pillar to post, get a second opinion. But let us help ourselves. Let these sessions count for something. Let it save your life or someone else's life. Let's share the word. Let's spread the love. And thank you so much to everyone for your time. And thank you to the wonderful team who work behind the scenes to make this work week in, week out. Dr. Lorretta Oduwari, Ogboro, Okor, our absolute pleasure for hosting you. But more importantly, we are so grateful for your time and for your input. And Sister V, Ebanks as well. God bless you. Over to James, who will be doing the closing. It's been my pleasure, Dr. Diana Santi, to host you on this lovely Saturday morning. God bless. Thank you.
Nice meeting you.
Nice meeting you.
Dr. Diana, thanks so much for that, for hosting the Health Hour today. I just wanted to say on behalf of all of the CAHN team that support and work that support these sessions every Saturday. Thank you so much, Dr. Diana. Thank you, Dr. Lorretta, and also to Veronica. Some really interesting, insightful information. As a man, as a dad, as a brother, really insightful and illuminating information. I can't believe that there, for example, there's so many different alternative treatments to have, and the etymology of hysterectomy and how that comes, kind of from the word hysteria is really interesting. And you can guarantee that I, for one, am going to be passing some of these things on to some of my friends and my family and colleagues, and hopefully that will have a broader impact, kind of with those men as well. So thank you so much. Thank you so much for that. Can I have the first slide, please? Okay, so upcoming events with CAHN on the 24th of September. If you're interested in knowing more about healthy lifestyle, you won't want to miss the session that we're having, which is a healthy living and lifestyle event. It's 12 till 5 p.m. And it's at the Community Action Project, Windmill Lane in Smethwick. If you want to come along to that, please do. Please bring some, kind of some family and friends. If you can get in touch to register with Angela Clark, the telephone number is 07985 445279 for that event. And again, once again, that's the 24th of September, 12 till 5 p.m. Our next CAHN session will be next Saturday on the 24th again, 11 till 12:15. And the topic is one that's really close to my heart, actually, because this is a condition that I had a variant of. It's atrial fibrillation. I had my condition ablated, actually, but and good outcomes, really good outcomes. So really interesting information about the process and what that means for you and your family. Dr. Deje will be hosting that one. So if you want to come along next week, 11 till 12:15, as every week for the CATHIP Health Hour. Healthy Arts session with Dr. Tukonubu on Tuesday, the 13th of September, 6 p.m. to 7:30 p.m. Again, please do spread the word around that and invite family and friends along to that one. Next slide, please. And you will find on the 13th of September, some of my colleagues across a range of different organizations will be speaking at a live event that is called Addressing Imbalance. So on the 13th of September from 9:30 till 3:30 in the afternoon. You can go in person or you can register for online. But colleagues from across the sector will be talking around imbalance within the sector and talking about how we can, kind of start conversations to address that and to work those things through. On the 28th of September, of course, we have our Black History Month CAHN event. This will take place in Manchester Cathedral. There'll be food stalls, dancers, singers, and people who read their poems, centre around the work of the topic of Black History Month. And you definitely will not want to miss that. Some great learning, some really good speakers, and a fantastic event for people to get involved with. On the 22nd of October, we have our annual gala. We would encourage everybody to come along, get a table, get tickets for your friends and your family. It's going to be a really amazing evening with some incredible speakers and a real celebration of the work of the organisation and some of the people that we interact with. Next slide, please. The other thing I want to kind of mention is that we have many different services, and of course, one of the key ones that we run as Spot is the Family Advocacy and Support Service run by my colleague Sandy. Please do come into the sessions on a monthly basis, 6 till 7 o'clock, please. And if you need, you need to contact the advocacy service or need to refer somebody through, please do pass on the telephone number, which is 07710 022 382, or people can email in to help@cahn.org.uk. And finally, just want to go through and thank our partners, obviously ourselves with the Caribbean African Health Network, CAHN. We have the Black Health Initiative, which is a community engagement organisation working towards equality and access. We're just flipping through the slides a little bit quickly. Sorry, there's a little bit of a delay on on my computer, but also we have our friends and colleagues at the Croydon BME Forum as well, and the Enfield Caribbean Association. Contact details you can see at the bottom of the page there. With the colleagues from our Royal Assembled Redeemed Christian Church of God, and these the link at the bottom there. And then finally, of course, RAFA International Development Agency. So once again, I just want to thank everybody for attending today. A massive thank you to Dr. Lorretta, to Veronica for the testimony and the kind of the speaking about our lived experience, and of course to Dr. Diana for hosting us again. Please do come along and join us next week, as in every week. Really interesting topics, always new stuff to learn. Absolutely be taking some stuff away from this week. And I wish you a very pleasant weekend and look forward to seeing you next week. Take care, everybody.
Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.